Good afternoon to everyone joining this conference session. I want to begin by saying what an honor it is to be with you all virtually today to share thoughts on a topic that is often overlooked but is, I believe, absolutely central to the experience of aging in our time. My name is Shakshi Priya Giri. I am an assistant professor of psychology at Srimati B.T. Jain Girls PG College, Agra, India. The title of my talk today is The Emotional Landscape of Aging, Reframing Loneliness as a Public Health Challenge. I hope to share with you some reflections, evidence, and practical ideas that can help us collectively rethink how we approach the emotional well being of older adults. Let's begin by considering the broader context of aging in today's world. The World Health Organization projects that by 2050, 1 in 6 people globally will be over the age of 65. That's more than 1.5 billion older adults worldwide. Much of the policy focus around aging, however, remains on physical health, on managing chronic diseases, preventing falls, ensuring adequate nutrition, and those are essential priorities, I believe. But there's another dimension that is often marginalized in public discussions and planning, that is emotional and mental well being. Older adults face multiple transitions: retirement, bereavement, changes in health, loss of independence, and among these challenges, loneliness stands out as both profoundly painful and profoundly under-recognized. So, what do we mean when we talk about loneliness? Loneliness is not simply about being alone. It is a subjective experience of feeling disconnected or uncared for or unseen. It's the perceived gap between the social relationships one wants and what one actually has. And this is not just a social or emotional issue. It's a public health concern. Why I'm saying this, it's a public health concern because research has consistently linked loneliness or chronic loneliness to depression and anxiety, cognitive decline and dementia, increased cardiovascular risk, sleep disturbances, even elevated mortality rates. One meta-analysis found that loneliness increases the risk of early death by around 26%. Another famous study has compared the health impact of chronic loneliness to smoking 15 cigarettes a day. It's a big thing. And yet, despite all this evidence, loneliness often remains invisible, unspoken in families, unaddressed in healthcare systems. Let's move now to look at some of the most recent evidence that underscores why this matters so much today. Here, I would like to highlight some of the most recent research and data from around the world. The World Health Organization in 2021 explicitly named loneliness as one of the major emerging risk factors for older adults' mental health globally. A 2023 meta-analysis led by Hort Lustad and his colleagues confirmed that chronic loneliness is linked to a 30% higher risk of mortality. This is not just a correlation, it's a clear health risk that can be measured at a population level. The Global Council on Brain Health in 2020 emphasized that regular social engagement is critical to preserving cognitive health in aging, with recommendations for policies to reduce social isolation. The UK campaign to end loneliness in 2022 reported that 1 in 3 older adults they say they feel lonely often or always. In Japan, the government created Asia's first Ministry of Loneliness in 2021, recognizing the scale of the problem and seeking coordinated solutions. And an EU-wide survey in 2023 found that approximately 25% of older adults reported feeling lonely frequently post-pandemic. These numbers remind us that loneliness is not just anecdotal, it's widespread, measurable, and growing that affects millions, cutting across cultures, language, and economies. As we move to the next slide, I want to discuss how the COVID-19 pandemic, in particular, brought these issues into even sharper focus. The COVID-19 pandemic did many things. It strained healthcare systems, disrupted economies, but it also magnified existing social vulnerabilities. For older adults, it often meant complete isolation. Visits from family stopped, community centers, places of worship, social clubs closed, uh, digital tools, while helpful, often left older adults excluded due to lack of access or familiarity to these devices. During this period, I had the opportunity to co-author a correspondence article published in The Lancet titled Loneliness in the Time of COVID-19. In that piece, we described how adults were experiencing profound emotional distress that was not being adequately recognized or addressed. We advocated for routine screening for loneliness in geriatric healthcare settings so that loneliness becomes visible, measurable, and treatable. Because, as we have seen, ignoring it has real consequences. Now, let's think about how these dynamics look in a specific cultural context, using India as an example. Culture shaped how loneliness is experienced, expressed, and even acknowledged. In India, for generations, elders were cared for within joint family systems. Living with children and grandchildren meant built in daily social contacts, a sense of purpose, and emotional security. But with rapid urbanization and labor migration, family structures have shifted to smaller nuclear units. Many older adults now live alone, are far from their families. Mental health stigma compounds this issue even more. Older adults may see acknowledging emotional pain as a sign of weakness here. They may not want to burden their children, and even if they want to seek help, language barriers can make assessment and communication difficult. Many standard psychological tools have been developed in English and Western contexts, making them less accessible or meaningful in local settings. These challenges demand culturally sensitive approaches, which brings me to part of my own research work. Recognizing this gap in accessible, culturally meaningful assessment tools, I conducted a study to adapt and validated the UCLA Loneliness Scale version 3 in Hindi. This study was published in Educational Gerontology this year. We followed rigorous translation, back translation protocols, conducted pilot testing, and administered the final version to over 320 younger and older healthy adults. The Hindi version demonstrated excellent reliability with a Cronbach alpha of 0.90 and supported the three-factor structure found in the original scale, developed by Russell in 1996. While this is just one step, It makes it possible for researchers, healthcare workers, and NGOs to measure loneliness accurately among Hindi-speaking population, that is more than 528 million, opening the door for better screening, understanding, and intervention. This experience also reinforced for me that recognizing loneliness is the first step to reducing it. But simply measuring loneliness is not enough. We must also rethink how we address it at a systematic level. It's time we treat loneliness as more than just a personal sadness or private burden. Loneliness is a public health issue. It has real, measurable effects on physical and mental health. It increases healthcare use, complicated chronic illness management, and leads to earlier institutionalization. Yet it remains largely unaddressed in most health systems. There is no routine screening, limited awareness, and few structured responses. We need to advocate for integrating loneliness screening into geriatric assessment, training community health workers to recognize and respond to it, and designing policies that prioritize social connection as a health intervention. Because ultimately, reducing loneliness is not about charity, it's about health equity and human dignity. Let's now consider practical strategies that have been shown to help foster emotional rejuvenation in aging population. Thankfully, loneliness is not a fixed state. With thoughtful strategies, we can support older adults in restoring emotional vitality. Here are four promising approaches I mentioned. The first, the first approach is mindfulness-based intervention. We can call it Vipassana as well because it's a Buddhist concept. Mindfulness or Vipassana help older adults manage emotional distress, reduce overthinking, and cultivate a sense of inner peace. Community-based social programs. The second approach. Local centers offering activities such as yoga, storytelling, gardening, or shared meals encourage older adults to engage and reconnect. The third approach is intergenerational initiatives, bringing together youth and elders for shared projects fosters a sense of purpose, belonging, and mutual respect. The fourth approach is culturally sensitive mental health support. Services in native languages with attention to local values and norms help reduce stigma and improve access. These strategies can be adapted and scale globally, depending on local needs and resources. They are not secondary extras, they are essential to any framework of healthy, dignified aging. As we approach the close of this discussion, I want to leave us with a vision. Imagine a future where no older adults feels forgotten, where health systems routinely ask about loneliness the same way they ask about blood pressure or blood sugar, where communities invest in intergenerational spaces, public transportation that connects rather than isolates, and cultural programs that honor old voices, where mental health care is available in every language for every person, regardless of ability to pay. This is not a utopian dream, it is a collective responsibility. Loneliness is a social failure, but it can be addressed with social solutions, and the time to act is now. Thank you. Thank you all so much for your time, attention, and presence today. I hope these reflections have encouraged you to think more deeply about loneliness as a critical, shared public health challenges in aging societies. I would love to hear your questions, comments, or ideas to collaboration. Please feel free to reach out to me at sakshipriyagiri@gmail.com. Thank you once again, and thank you so much, the contents team. Namaste.